Good afternoon. I'm Dr. Liesl Bryant, and I'm delighted that you're able to join us for today's webinar. As a trust policyholder, most of you are likely familiar with our risk management consultation service, the Advocate 800 program, which is one of the many benefits insureds receive through the trust. I am one of the 8 advocates, and I'm really excited to be joined by 2 of my fellow risk managers, Drs. Julie Jacobs and Joe Scropo. In the interest of time, our bios have been placed on this slide here. Welcome, Julie and Joe. I'm excited to be here with you all. And Julie, I'm going to start with you with our starter questions. We get many questions on minors. So let's say that a clinician is going to start working with minors in their private practice, or really in any practice. And is wondering about sort of basic risk management strategies when working with minors. So what would you say they should consider as they plan to move into that area?
Yeah, it's a great question, and gosh, we get variations on this all the time. As is always the case when you move into a new area of practice, the basic threshold consideration is competence. So, minors aren't just little adults. They have their own set of needs. They have very different ways of working with minors than working with adults. So you want to make sure that you have appropriate training in working with minors, that you seek consultation with folks who have a little more experience when you hit any stuck points. You might want to start with a smaller caseload, so just pick up a few minors at a time so that you can test the waters and see what your comfort level is like with that population. But those basic risk management tools of ensuring competence and consultation are really important. Informed consent can be of particular importance when you're working with minors. I think many of us will acknowledge that it is parents often that cause some challenges versus the minor client themselves. So if you set really clear expectations through your informed consent process, you can avoid surprises and confusion during care. You can get everybody on the same page, including the minor as is developmentally appropriate. You want to outline the basics that we always outline for informed consent, the nature of the services, the course of therapy, risks, benefits, fees, confidentiality, and especially your role and the boundaries of your role as a therapist. Specifically, if you're a treating therapist and not an evaluator, you want to be really clear at the outset with the parents that involving you in legal proceedings is not part of the package, that is not something that you would choose to do, that could interfere with the therapy process. It could be disruptive and may not be in the best interest of the minor patient. So kind of talking about the fact that your focus is on the clinical needs of the minor and that you really can't make recommendations or opine about parenting or custody situations other than doing sort of parent education and things of that nature. And then consent for treatment. Who can consent to the care of a minor? As a general rule, parents are the personal representatives of their minor children for the purposes of consenting to care. If parents are married, then generally either parent can consent to treatments. If parents are divorced or separated or have not been married, then you want to determine who has the legal authority to consent to care. So if there's a court order or parenting plan in place, you want to ask for a copy of that. Ask the presenting parents. Who has medical decision-making for this kiddo? And a lot of times it's going to be shared medical decision-making. And this is separate and apart from physical custody or other issues. So you really want to review or have someone you trust, an attorney or risk manager, review a court order and help you determine who has that legal right to consent. So if one parent has full medical decision-making, that parent can consent to care. If they share it, then you would need both parents to consent to care. And also important to remember that consent is not the same as access to care or access to information about care. So just because one parent has been allocated full medical decision-making doesn't mean the other parent can't access information about care. So make sure that you understand your state laws. If there is a protective order in place or something that somehow limits that involvement, you want to be aware of that and get a copy of that. And then real quickly about minor consent to care. There are some states that do allow minors to consent to their own treatments. Those are often permissive rather than mandatory, so they would allow that, not require it. If you're considering having a minor consent to their own care, be really sure that you understand the laws around that you understand your state law and what hoops you might need to jump through in order to allow a minor to consent. So Colorado has a minor consent law, but there's various clinical determinations that have to be made before you can actually let the minor consent on their own. So that's sort of a quick overview of some of the considerations.
Great, that was perfect, Julie. Joe, anything you want to add there?
Yeah, just one quick point. One thing that we get on phone calls, parents thinking that their communications with you are somehow confidential when they meet with you individually. It's best to establish a rule about that as soon as the parent comes in. The easiest thing to do is to say to both parents, whatever you tell me could go in the chart and be available to anybody who has access to the chart. This saves trouble later on when a parent claims that what they told you should not be disclosed outside of, or to anybody else. So it's best to address that right up front and be clear and save trouble later.
Yeah, that's a great point. And I think both of you have mentioned this idea of setting clear expectations, right? Which is just huge when working really with anyone, but certainly families. And I do want to just mention in terms of resources, on our website, we do have a sample informed consent with an addendum for minors. That's in the document library, which can give you some good language. And then to Joe's point too, we also have a collateral party agreement. And that will give some information as well about some of the issues that Joe mentioned, who has access to the record and whose information is it, that kind of thing. So both of those can be useful. Great. All right. And I think they did put the link for that in the chat box, so you guys can have access to that. Okay, so Joe, I want to switch topics for a little bit, but a little bit similar. We get asked a lot of questions about conjoint therapy, couples therapy. So I wonder if at first you could just really distinguish between those, right? Couples therapy very specifically and conjoint therapy broadly, and then discuss a few of the central risk management issues in that, such as why knowing who your client is really matters, who is it that has access to the records when there's more than one party, and even some of the somewhat complex insurance billing issues, in particular related to couples treatment that we run into.
Okay. Well, in my mind, I don't really distinguish too much between couple or family or conjoint therapy. There are people who use the term conjoint to mean that there are two therapists or more working with multiple individuals. But for the purposes of what I'm going to say, it's essentially any time there's more than one patient that's involved in the treatment. And I'm going to call it conjoint or couple or family. But the key thing is that there's more than one patient in the unit of treatment. This is in contrast to where individual therapy, where there's only one person and things are a lot simpler. So I'm going to say a little bit more about couples or conjoint therapy, but I want to emphasize that state law is always kind of joker in the deck, and whatever I say, you want to be cautious because your state, for whatever reason, may not follow that same approach. So why is it worth exploring a distinction between individual and conjoint therapy? But one reason is that at all times, you and the patients should know who is a patient and who is not. Unless you make that clear, it's easy for folks to get confused, the people that are in the room with you, or for you to sort of think, to slip into a mode of bringing in somebody as a collateral and then somehow working with them in a way that's more patient-like. So the most important principle in couples or conjoint or family therapy is that everybody know their status. Am I a patient or am I a collateral? And there are fundamental differences with both of those roles. So we owe patients more duties than we would a collateral. We have to maintain the confidentiality of patient communications. Collaterals, on the other hand, may sort of have a moral right to confidentiality, but legally they're not patients, and thus the rules of confidentiality don't apply. We have to keep records about patients. We don't have to keep records about collaterals. Patients can access the chart potentially, collaterals cannot. Um, we have a duty to assure continuity of care for a patient. We don't have that same duty because we're not caring for the collateral. Um, we also have a wide range of mandated duties that apply to patients, much fewer that apply to collaterals. Those are the differences and why it's important to know what the differences are. Um, so in terms of the mandated duties, we know that for patients, we have a range of them: child abuse reporting, duty to protect, uh, im- impaired healthcare professional, adult abuse reporting. These, some of these will cut across both collaterals and patients when in the room together. So child abuse reporting would always be relevant, no matter whether someone's a collateral or a patient, because you're in your professional role. Duty to warn or to protect, however, applies only to a patient. We have control, potentially or supposedly, over patients, and thus we can have a duty to try to protect others from the patient. We have no control over collaterals, so there's no duty to protect that's invoked by a collateral in the room. Now we have on our website a collateral informed consent that I think is very helpful to have. You can find it at trustinsurance.com, and it clearly explains to the person who you're going to give it to, who's the collateral, that they're not going to be able to access the record. They're not going to be able to see notes about what they've said to you, and that you will write stuff about them that they can't see or access at any point. So it goes over those issues. You can also modify it to indicate which mandated duties you're going to apply to the collateral and which you're not. So what determines who's a patient and who isn't? It's really the mutual agreement between the therapist and the folks in the room. That has to be clear. And you may want to remind people what their status is. So if you bring in a spouse or partner to help an individual patient with their therapy, that person is a collateral, and you want them to understand that and make sure they understand what the expectations are. Now, when you do have couples or family therapy, one issue that comes up a lot is access to the records. So now you have two or more patients in the room. Who can access the records of that couples or dyadic treatment? We suggest adopting this policy that unless all the patients agree, no one can disclose the records. In other words, everyone has to sign an authorization before even the participants themselves can see the record. Why is this? It's important to explain to patients why. That otherwise, one person can get the records and use them against the other participants in the treatment. Send them to the person's boss, send it to their employer. So we recommend making that clear, both in writing and orally, at the very first meeting with regards to record access. Sometimes you'll get pushed, they'll be pushed on this. There are a couple of fallback positions, like saying I can write a summary that is about only one person, or I can redact the record that so that only information that appears is about the one person authorizing. But these are not great choices, and you should avoid them. I'm only mentioning them if you get a tremendous amount of pressure, and you can consider them then. The last part is insurance, that insurance requires that there be one patient, an identified patient. The model that we're speaking about clinically, the unit of treatment is more than one person. And those two models simply don't, they're irreconcilable in some way. If you're going to do an identified patient model, you need to make sure the documentation reflects that the interventions are to address the identified patient's issues. And the chart would be in the name of that identified patient. But the reality is the clinical reality, which is that everybody's a patient and everybody in that unit should be given confidentiality. So the best you can really do is, if you're going to use the insurance model, indicate that it's for billing purposes, but that the clinical model is what prevails in terms of who's a patient and what rights they have.
Great. Julie, thank you, Joe. You covered a lot very quickly, which is great. Julie, anything you want to add there?
Just really quickly, excuse me, with the collateral information, you want to be sure that you also respect those boundaries that you're drawing, and that in the session with the collateral, you don't start to do therapeutic work focused on the collateral. And it can be hard for us when we see a need or an obvious place for an intervention to not jump into that role, but it's just as important that we respect the distinctions that we make as it is to explain them to the client. And I think sometimes that can be tricky for us.
Yeah, no, I agree. I agree. Okay, so Julie, let's head back then to the issue of minors for a moment. I want to follow up there a little because, as you know, one of the issues that comes up, particularly with teen patients, adolescents, is the adolescent says, look, I'm not going to share anything with this therapist if the therapist is going to go tell my mom and dad what I said. And of course, mom and dad are like, well, yeah, but I want to know and I need to know what's going on in my kiddo's treatment. So what risk management strategies can you suggest for how clinicians can sort of, thread the needle there and walk that line?
Yeah. I mean, it's a great question. There's just that inherent tension anytime you're working with an older minor that's, the parents are paying you, right? You're working for me, but we're trying to restrict that access. So, as I noted earlier, parents from a legal standpoint are generally the personal representatives of their kids. So they do have the right to access the full record of the care that's being provided in most cases. And there aren't a whole lot of exceptions to that. But like you mentioned, teenagers aren't going to talk if they know you're reporting back to their parents. And so what we try to do from a risk management standpoint, we really go back to the informed consent process. And, the informed consent, the sample consent form that Joe alluded to and that we've got the link for in the chat addresses this explicitly. And it really talks about the importance of creating a zone of privacy around the work that's being done with the older minor. So it talks about the fact that, yes, as the parents here, you may have a right to access this full record, but I am asking you as a therapist to respect the fact that your child, my patient, needs a zone of privacy. They need to be able to trust that they can tell me things and work effectively within the therapeutic space. And so it outlines real clearly, yes, you have a legal right to this information, and I'm asking you not to access it. And it indicates that, as a therapist, I will use my judgment to determine what you need to know. If there's a safety issue, if there are, high level concerns, trust me to share those with you. Otherwise, I'm going to try to keep the details of the work that we do together pretty private. And it can be good to go through hypotheticals with a parent, and make it really clear that, if your child tells me they're experimenting with alcohol, I'm probably not going to tell you that. If your child tells me that they're drinking and driving or binge drinking or engaging in more risky behaviors, then yes, that's something I will tell you. And this conversation needs to happen with the parents and with the minor present. Everyone needs to be on the same page and understand so that the minor can see that you're advocating for their privacy, but there will be limits to what you can do. So you can't necessarily stop the parents from asking for more information. You can refer them back to what they agreed to earlier and say, please respect the agreement that we had previously. And that addendum, the child adolescent addendum, covers a lot of other really important things. So I would say, in the interest of time, I am not going to go through the list of all the good stuff on there, but I highly encourage anyone who works with minors to take a look at that document and look at that addendum and see what might be valuable in just helping manage the inherent risks of working with a teenager and all of the tensions that come along with that.
Perfect. Thank you. Joe, any addition there?
Just real quick, you want to try to settle these issues informally if there's a conflict between the parents wanting to know and your view that this wouldn't be helpful to the child. If it goes beyond that, states generally have a mechanism and a threshold at which point the therapist can withhold or limit the disclosure to the parents. And HIPAA has a more extreme version when the parent you believe is a potential risk or has abused or neglected the child. So it's best to work these out informally, but ultimately there are some legal measures that you can take if you believe the disclosure to the parents would create serious risk. So just bear that in mind.
Yeah, no, that's a good point. And I'll quickly just add too, I love Julie, what you said about giving those hypotheticals, because oftentimes if you give those hypotheticals, especially like you say with parent and teen in the room, one or the other of them may say, hey, I don't want to do this if we're, if that's your policy. And you actually do want to know that in that first meeting.
Yeah.
So like Joe says, it can be worked out or not, but you don't want to be 6 months into therapy and then have that come up, right? That's where we see a lot of the really stickiness. So. Great. Okay. I'm sure we're going to get more questions on that. But Joe, I want to fit in the very last question for you before we head to the live questions. Going back to the conjoint treatment for a moment and specifically looking at reunification therapy, which, as you know, is a specialized service, court-ordered service. Can you speak to some of the risks and then a few of the risk management strategies for doing reunification treatment?
Yes. So reunification therapy is when there's an estrangement between a child and a parent, or children and a parent. And typically, the court will get involved because this occurs in the midst of a custody dispute or some other conflict between the parents. And the court will direct typically that the family find a therapist who can try to strengthen the bond between the estranged child and the parent at issue here. It's very different from regular private family or couples therapy or individual therapy, because there's an entity kind of overseeing this. The way it would typically happen is that a couple would come to you or a family would come to you. They say the court has issued us an order. It says here that we're supposed to get reunification therapy. They may even name you in it. They may have found your name somewhere, or someone may know you, and your name is in the order. But the first thing to know is that you're not bound by those kinds of orders. The court order binds the family, not you. So don't, and therapists sometimes see a court order with their name in it and assume that they're bound by it. But the rules of court jurisdiction are complex, but you generally are not going to be subject to any jurisdiction when people come to you at the court's request. So if you don't like the case, you can turn it down. The conditions in the order may be such that you think they're not really therapeutic, or they're counter-therapeutic. So a second issue is to look at the order, and often, most of the time, it's incomplete. There's not an issue of who can access the information from the reunification therapy, when the therapist can disclose or and can't to third parties like the court or the attorneys. So you're typically going to see an incomplete order for reunification therapy. And so what I would suggest you do if you're willing to take the case, is to have your own detailed reunification therapy informed consent. You can find models for this at afccnet.org, afccnet.org, under resources at court-involved therapy. And when you do that, you send your informed consent, your detailed one, to the family, to their attorneys, and say, look, these are my rules and my procedures for reunification therapy. If you want me to do it, this is what I need you to agree to. So in absence of the court's guidance, you provide the guidance and make sure that everyone agrees and stipulates that they will follow those conditions. It's high risk work. It's an adversarial setting. There's often going to be people unhappy with whatever you do, one or the other parent, possibly the child who feels forced to be in the room. So you do want to make sure you're competent to do this and can get consultation about it. And you also want to make sure that you address in your detailed informed consent who's going to pay you, because the parents are going to say, no, he should pay or she should pay. So you try to envision all the kinds of problems that can arise and try to address them in that informed consent that everybody signs on to before you start. And just be aware that it's often unsuccessful. The data on reunification therapy is such that many times it won't succeed. So be aware when it's come to a dead end and be prepared to stop at that point.
Great. Great. Once again, you covered a lot very succinctly. So Julie, anything to add there?
To reinforce the fact that just because your name is on a court order does not mean you must do the work. I've had callers who do not do reunification therapy, have never done it, and they get court ordered to do reunification therapy. So if it's not within your scope or it's not a case you can take, you can ask for, you are not bound by that order. I wouldn't just ignore it. I would communicate that to the folks who've reached out to you, but don't do the work just because the court orders it if it's not something that you are competent and capable.
Right. All right. So already we've heard in those questions multiple of our general risk management strategies, right? Good use of informed consent, using that as a process, frequent consultation with a low threshold. Maybe you hinted at careful documentation, but we know that's a key part. And the one that I'm sure we'll get to at some point, but is also prioritizing self-care. And like you said, Joe, in particular with reunification, that's not only high risk work, but it can be challenging work. And so I think, tending to our own self-care is really important when we're doing that kind of work, or anytime we're working with high conflict families as well. So, all right, on that note, we will turn toward the live questions, and it looks like we're gonna bounce around, which is perfectly fine. So the first question is a telesite question, and Julie, maybe we'll start with you. If a client lives and works in your state of licensure, then moves to a neighboring state, but continues to work in that original state, can you see the client from their work office when they're in the original state?
Yeah, it's a great question. And yes, generally it is where the client's body is located during the time of service that determines what credential you need to have. And so if they live over the state line, but they are driving into your state and sitting in their office in your state while you're providing the service, then from a legal standpoint or from a licensure standpoint, that is permitted. Now, there's other issues with doing therapy while you're at work. So you want to make sure that they understand potential confidentiality concerns and that they're not doing therapy sessions where people can hear them and that they're using a work computer or whatever the considerations may be there. But from a regulatory standpoint, you want to be licensed or credentialed working under SIPACT or some credential where the body of the client is located during the services.
Yes, beautiful. So primary residence, secondary place of residence does not matter when it comes to the regulatory issue. Yeah. Joe, any addition you want to add there?
Yeah. I mean, I would adopt the policy or suggest you adopt the policy of always recording where the patient is at the start of each remote session. Where are you? You get an address, or you may need to send help. It's rare, but it could happen that something in that session is going to trigger the need for you to send 911 or the police. And also just so you know that you're satisfying the regulatory requirement by documenting. Now, you don't know whether the person's really there or not, probably, but you've made the effort to inquire and they've told you. And that's showing good faith effort to make sure that you're not violating the prohibitions on interjurisdictional practice.
Yeah, that's a great point, Joe. And I like it too, because if we get our clients in the habit of telling us where they are at the start of each session, it's much more likely to come up if now they're going to be in another jurisdiction 3 weeks from now, right? Because they know that's an issue, they know we're asking them. So that's a great habit, not only to get into for documenting, but also just to sort of, in essence, teach your clients that this is a thing that has to be talked about and you need to know about changes in jurisdiction in advance, ideally. So great point. Okay, Joe, I'm going to toss this one to you. You may not be able to answer all of it, but if you can give us some general guidance. The question here has to do with signing up for a Zoom account. And there's some concern about all the back and forth it took to get the BAA, which, as we know, details HIPAA issues. And the question is, have you gone through the document, meaning the BAA, about what are the privacy confidentiality concerns that maybe you would suggest they think about. And then they also note, I've received a copy of the consent to educational data collection, which they're being told they have to sign. So can you give any guidance there? I know you don't have the answers. We haven't reviewed those documents, so we can't speak specifically to those, but can you give some guidance on what folks should think about with those kinds of documents and signing that kind of stuff?
Mm-hmm. Yeah. So I'm sorry, I sort of just lost the thread. Could you just summarize it one more time?
Sure. So the main thing, like in this case, it's an example with Zoom, but when you're signing the BAA, how do you know, is that a good BAA? Is it sufficient? Is it not? The language, that kind of thing. And then also they're saying they're being asked to sign a consent for educational data collection. Okay. I know less about that, but yeah, does that help?
Yeah, the BAA, the Business Associate Agreement, is a requirement under HIPAA when you entrust protected health information to someone who's not an employee of yours. So because you're using a service that potentially is going to have access to PHI, the remote video service, the BAA is a way to ensure that if the video service screws up and causes a breach, that they're on the hook to fix it, and potentially can be sanctioned by HHS, the entity that administers HIPAA, if they are careless or negligent. The required contents are, you can find them by going to HHS HIPAA breach, I'm sorry, Business Associate Agreement. And you'll find a template BAA. So one way to do it is to compare the one that you're presented with the one that's on the HHS website. If you see things that are not in the HHS template but are now in this one that you've been presented with, that's a red flag that maybe something has been added that doesn't have to be there. But when you sign it, it may obligate you to be bound by it. So I would do a check and see that it closely mirrors the one that's put out by the federal government. And if it doesn't, that's a sign to stop and pause, and because they can be modified in ways that go beyond what is the minimum amount. And unfortunately, people think that a BAA is one document, but it's not. And this is sort of how some of these video services got away with sharing information that they probably shouldn't have, that they acquired from the users, because they added into the BAA a provision that was questionable. So really, you're not a lawyer. You can't, it's difficult, impossible really to analyze it from a legal view. But just as a shorthand check, I would suggest doing what I said. And if that something seems off, then call us or consult an attorney and satisfy yourself that you're not obligating yourself to something that's not good for you or your patients. The second part, I don't know what that is. I've never heard of that. So I'm not going to be much use to answer that question. It may pertain to Europe has its own equivalent of HIPAA, and if you do international teletherapy, you need to be aware of the European Union's own confidentiality requirements. But I don't think that's what that was about. So I'm just going to plead ignorance.
Well, yeah, no, that's great, because I think also to your point, that's a great place for consulting, right? Reaching out to us at the trust or to an attorney or someone, letting them look at the documents, that kind of thing. Julie, anything to add before we turn to a couple questions on minors?
Yeah, just to say that this got way more complex recently, especially with the AI, the advent of AI. I mean, it used to be a couple of years ago, I think we would have felt more comfortable with, oh, they're offering you a BAA, and you can probably hang your hat on that. They tended to be pretty standard, but now there's a lot of companies who want to use information internally or maybe externally to train these AI models, and it's gotten very convoluted. And so I do think that, this isn't exactly on point for this question, but I think that a discussion to have with clients generally about privacy and confidentiality is this kind of brave new world of AI. And that although, a company may sign a business associate agreement and agree to not disclose information that they consider to be PHI, we don't really know what they're doing internally with information. They may be de-identifying it and allowing it to be used for AI training purposes. So I just think it has gotten complex, and it's something we can talk to clients about and say, we will obviously do everything we can and enter into business associate agreements and try very hard to protect the privacy of your information, but there are some internal uses that we may not be aware of. And it just lets clients, we're all living in the same environment right now with this tech, so I don't think anyone would be surprised by that, but it just sort of speaks openly about the thing that's going on behind the scenes in a lot of these companies.
Yeah, no, that's true. And it is a bit far afield, but I think it's a good point, because we all have to be asking more questions, I think, as clinicians, right? So that we can understand enough to know what to say to our clients. So that's a really good point. Okay, a couple of quick minor, this first one I think is a quick minor question, and then some more complex ones. But Julie, I'll send it to you. What age range constitutes minor by category? So I think basically like how do we define
Yeah.
minor?
I mean, generally a minor is 17 or younger, anybody under 18 as a general rule is considered a minor. And now some of these minor consent to care statutes will specify minors 15 and above, minors 12 and above, whatever the case may be, but they're still minors. And so I would say, I don't know of any state, and you guys can chime in if you do, but I think that fairly consistently across the board, 18 is when you are at the age of majority and you are no longer a minor.
Yeah, that's my understanding too. And Joe, I'm going to send this one to you, and it's related to something Julie just said about. So they say in California, minors can give consent at age 12 based on need. And the question is, how would you clinically determine need? So I know that's a lot, but if you can give some initial thoughts on what they might should consider there.
But it isn't based just on need. There has to be a maturity. You have to assess that the minor is mature enough to understand the basic parameters of therapy. If you feel that they don't understand the concepts of confidentiality and other relevant issues, then you can't accept that. You cannot allow them to agree. So there's a sort of maturity level that you need to document when this happens. Generally speaking, when a minor authorizes for themselves, nobody can access the record. Only the minor, and only the minor can allow others. So it becomes an entirely hermetically sealed treatment, which may not work or may not be a good idea in a particular situation. Um, in states that do have minor based authorization, it's important to be aware that that there's really a different channel. There's parent initiated authorization, which is what occurs most of the time. And in states that have a provision for minors, there's a minor initiated authorization track. And there are laws and regs that apply differently to those tracks. So you want to be clear that it's two different processes that you're going to have to handle in two different ways, which means you need to know what the specifics are of essentially minor initiated authorization before you start doing it. Um, and just to add a little bit to what Julie was saying, yeah, there are a couple of states where 19 is the age of consent. So you can Google your state and just, what is the age of consent in Illinois? It'll tell you. There's a couple. I'm not sure exactly. They're not coming to mind at the minute, but there's a couple. And also, folks can get emancipated as minors. That means they are living on their own, or they've gotten married, or they have given birth to a child. There are some circumstances that would automatically emancipate for various purposes someone who's still a minor. The basic point is be careful when you offer minor initiated authorization. There's a whole bunch of consequences that are going to flow from that decision. So know enough about the state law or consult to find out before you start going down that road.
Yeah, so I want to underscore one thing, and then I'm going to add this next one, which is very related. And then Julie, I'll let you jump in too. But one of the key things, Joe, that you said is you got to know the state law. And I just want to underscore too, if you were doing telehealth with a minor in another state, in a different jurisdiction, you need to know that jurisdiction's state law on minors as well. So it's not as simple as just knowing the law in your own state if you're doing cross-jurisdictional work. And Joe, you sort of hinted at this, but just to make it really clear, because it's so connected here, the next question is regarding states that allow minors consent, what about signing ROIs? Let's say in a situation where a therapist will exchange info with a teacher. And I think the question there is if you're seeing a minor under one of these minor consent laws, who is it that signs an ROI for the therapist to talk, say, with a teacher or a pediatrician or that kind of thing?
Right. Yeah, almost universally, if it's a minor initiated authorization, the minor controls the record completely. So in order to disclose any info from the minor's record, the minor would need to authorize, which can create problems, obviously, if the person is choosing not to authorize when, in your view, it may be essential or really important. But that's the way it works. Minor initiated, minor based authorization. The treatment almost always means the minor controls the record completely. There are a few states like Illinois, which when the child reaches 12, the child can withhold some information from their parents, but the statutes in Illinois allow the parents to access a bare minimum amount. So there are some states that try to strike a balance between protecting the child's confidentiality and making sure parents have the ability to get some information. So if you're in a state like that, you need to know where that cutoff age is and what information can be given to the parents regardless of the minor's expressed desire.
Mhm. Great. Julie, anything you want to add there?
Just to really underscore and emphasize the importance of understanding that it has to be minor initiated care. Like the minor has to show up without, it's not parents bringing in a kid and saying, I'm going to pay for my child to have services, and then you decide the child's going to consent to their own care. That doesn't really fit this paradigm. And I think that piece is really, really confusing to people. And I know, Joe, you said it 10 times, but I still think people don't recognize if parents are going to pay for care, if parents are bringing the kid in and saying, here, serve my child, that's really a situation where parents need to consent. That's not really a situation where the minor is going to hold privilege on their own behalf and they're going to control the record in the way that Joe just described.
Yeah, in fact, I think some, and Julie and Joe, some of those statutes actually say that if it's minor consent, you can't bill the parents, right? Depending on, Joe, go
Yeah,
ahead.
I was just going to say that. I
Yeah.
mean, that sort of renders some of these issues moot.
Yeah.
That the parent won't have to pay for minor initiated therapy. Almost invariably, the minor or somebody else has to volunteer to pay. So yeah, there are rights. The minor has rights, but in the real world, that may not translate into them being easy to treat because you may not get paid for doing that work.
Mhm. Yeah, so I think one of the things that we're hearing here is there is some complexity to this. And so again, I want to just underscore, have a low threshold for consulting and consult frequently. And this is an area that's really important to consult in, to make sure you're in line with the law and that you're not either withholding or offering information that you shouldn't in either direction. So, okay, Julie, I'll toss this one to you first. I know it was the topic Joe started with, but we'll get his input in a minute. The question here is about couples work. A lot of clinicians think you can bill insurance for couples work under one partner's name, but aren't we not supposed to do this anymore since there are no more Z codes? Can you
Yeah, I
speak?
mean, Joe kind of tried to touch on this, and I think this is a huge issue and always really confusing. And I think the way Joe framed it is kind of the insurance model and the clinical model. And so, you know, I mean, I always kind of fall back on if the couple is the couple is the client for all purposes. But in the systems within which we work, if you take that stance, you're never going to get insurance reimbursement because it's very, very hard to say the couple is the client and not to assign an actual diagnosis to one person that's going to be billed for and reimbursed for. So I think there's a disconnect between the clinical reality and the administrative requirements for billing. And I think that, you know, that a very, you know, a completely ethical, you know, a way to look at it is couples counseling is probably not going to be reimbursable. The couple is the client. We don't have a diagnosis. We don't have an appropriate reimbursable CPT code. And that means anyone's going to have to pay out of pocket to get couples counseling. Or we work within the framework of the system that we have right now for insurance that basically says, no, you got to pick someone, identify that as the patient, the sick person, give them a diagnosis, and then you can provide services in that way. I mean, I have sort of a moral issue with that, but that's a systemic issue. And so I don't think there's a good, clear answer. I mean, the way to get reimbursed is to follow the requirements of the reimbursement models we live in and to identify a patient, give them a diagnosis and bill in that way. But I think Joe made a really nice distinction of explain this to the client and say, or to the couple and say, you know, clinically, I am conceiving of the two of you as my client. For the purposes of billing, I have to identify one of you, but that does not reflect my clinical conceptualization or how I am going to actually work with you. It's just a billing requirement. I hate this question because I hate that disconnect between what's the clinical reality and what we have to do to get paid.
Yeah.
Joe, do you want to add anything there?
Yeah. Yeah, in an ideal world, the couple would be the unit of treatment. And you may think that may be good news in the sense that you're not going to have to deal with insurance companies if you tell folks this is couples therapy and it's not going to be covered. So have to work out a private fee. Um, that may limit the folks who you can work with, but it eliminates the insurance company, which could be good. And it's true to the actual spirit of what you're doing. If you do go for the insurance model, the insurance company cares about money. That's their bottom line. And what they're going to care about if they audit the chart is to make sure, A, that there's medical necessity so that the person who you've identified has a diagnosable condition that qualifies under the insurance company's policies. And second, that the documentation supports that the interventions made in the course of the work somehow address that diagnosis. As long as that's there, the insurance company is basically satisfied. That's what they care about. Um, but it does rest and sit somewhat uneasily with the reality, which is the clinical model. They're both patients and so on. So between those two, if you have to choose which one to follow, it should be the clinical model in terms of dealing with any issues that arise in the treatment. The payment, if you're going to do this, you're going to just do the payment under that insurance model. Everything else will fall under the clinical model. Again, it's not ideal, but it's better that what can happen is that the identified patient, for example, will try to deny access to the records to the other person claiming they're not the patient. And you've set it up in that way, and that can create a problem. So there are messes that are bound, but if you do it, there is a way to do it that can hopefully minimize the problem. And that's by insurance is just addressing payment. Everything else is clinical.
Yeah, I really appreciate you guys pointing to the complexity here. And I want to add one caveat, which is that if an insurance company explicitly has said that couples therapy is not a covered service, then I think you've got to be more careful, because I think that could be interpreted as fraud, right? If say, I don't want to name one, but X insurance company says, we do not pay for marital couple or couples therapy, and you then bill it as something else in order to get covered, I think there's some risk for that if you get audited. So I think it is complex. Yeah, so I agree, Joe, that the safer way to go is that clinical model. If you are, my opinion, and I'd be interested if before we move on, if there's other thoughts on this, my opinion is if you're going to do the insurance model, sometimes it's a really good idea to check with the insurance company to find out if they'll cover couples work. If you can certainly get that from them, that helps a little bit. But I do worry in those cases where a company has said, no, we don't cover it. And then in essence, it's billed as individual or family in order to get it covered. That's where I worry. I think that has some risk. So any comment from either of you before we move on?
Yeah, I think insurance companies they know that this is what goes on. They know that people use this subterfuge. And often clients want this kind of treatment. So the insurance companies tend not to make it too difficult when you use the identified patient model. It's sort of like everyone looking the other way because there's a genuine need for the service. People who buy the insurance want treatment for things that they think are really significant, like marital problems or couple problems. But you can't count on that to keep you out of trouble. So, be vigilant, make sure that your documentation supports your billing. And that's about really the best you can do to minimize the risk.
Yeah, I agree. And there are a few insurance companies that say they will cover it that way. So that's helpful. If you get that from them, that's definitely helpful. So, okay, I want to keep going so we get into a few more different topics here. Here's a question. What are the implications of conducting family therapy with adults when one member is in a residential program? Specifically, what happens regarding information about other family members in the clinical record of the resident? Does that make sense? Do you want me to repeat that? Maybe Joe, I'll let you start with this because I know you were talking about this. So you're doing family therapy. but one person is in a residential treatment program, are there implications for information of other family members in the residential treatment record?
I guess it depends who's doing the therapy. If it's someone within the residential setting, so that there's going to be notes made in the patient's residential center chart, then that has to be discussed with the other participants. Um, it it I mean, it would, if you're going to do that, you probably are going to have to identify in some way who the notes are about. Otherwise, the notes are not going to make any sense at all. So putting people's names in a chart is expected, and I don't think that patients or people in a session would object to knowing that the therapist is going to write down their name, who they are. If your therapist is outside of the residential center, then the notes are kept as we've discussed by that therapist. There'll be no notes made in the residential center EHR. But I would assume that consent is given by the family when they choose to participate in the residential center's family therapy program, let's say. And they should be an informed consent and all the other issues we discussed regarding clarity about patient versus collateral.
Okay, great. Julie, did you want to add anything? I'm going to try to fit in two more questions if we
No,
can.
I think it's the same distinction. Who's doing the therapy? Is it in the residential center? Is it an external provider? And I think the answer flows from there.
Perfect, perfect. So this gets into a little bit of the record keeping again. So if, let's say, a clinician is seeing a couple, and as a part of the assessment phase, they meet with the individual partners for one session, right? Meeting with them individually. They say here that they put joint session notes into a joint couples file that they both have access to, and then they put individual session notes into an individual file that only that individual has access to. And the question is, does that work? Are there risks or other recommendations? Julie, do you want to start that one for us?
Yeah, I mean, my preference, and I know there are many different ways to do this. I think it's much simpler to have, I mean, if you are doing couple therapy or family therapy and that is your client, there should be a record for that. And clients should be informed that if I do occasionally do breakout sessions with you individually, that information goes into the main record. There are no secrets. To have a no secrets policy to me is a risk managed way to do it. And I know that's not the model that everybody works in, but I think that's my preference, to have a really clear no secrets policy outlined in the informed consent for both partners, and to indicate that, yes, part of my model is to do individual sessions and gather information, but these are not opportunities for you to tell me secrets that you don't want to bring into the main therapy, and that the information you share in those sessions will be in the couple's record. And I think that also harkens back to what Joe was talking about when you're working with a couple or a family, to get ROIs from both members of the couple or all members of the family before anyone can get that record, because there may be notes that are about an individual session that occurred. And so that, I know there are different ways, so I'd love to hear Joe's take on that, but to me, that simplifies the process. And there may be couples that aren't willing to do that. And again, that's important, because you're telling them how you operate. And if they don't like how you operate, they can choose to find someone who operates differently.
I would answer this question by saying that you need to identify the unit of treatment right at the outset and stick to that. And that then controls who's a patient, so that even if you're having an individual meeting with someone who's in a family therapy or a couples therapy, that's still family therapy or couples therapy, because it's being done in furtherance of the treatment that the people have signed up for. And they may say things in their individual meetings that clearly they're disclosing because the unit of treatment is the couple. So I would not regard individual meetings with couple or family patients as somehow discrete from the chart or walled off. That's a little different from keeping secrets. The therapists can, or some are willing to maintain secrets from that one patient discloses and doesn't want disclosed to the other. That's a little different. but that there's a choice there. But nothing is going to change the fact, in my mind, that it is a couples or family therapy. And you cannot separate those out into individual notes that apply only to that person. I would regard the entire record as being addressed to the unit of therapy.
Yeah, and I really agree. I think too, back to what you said in the very beginning, Joe, about who's the client, it's really important that you, the clinician, and the patients know that. And so if you're, I think it gets confusing for clients if you're saying, oh, this session I'm going to put in a couples record, but this session I'm going to put in your individual record. They may feel like they're having individual therapy with you, and that can get risky, right? That's where you can blur those lines and have dual roles or multiple roles, and where the risk can increase. And I just to say too, the secrets issue that both of you have mentioned is good. There are multiple options. Clinicians can choose what to do. I think what's really important is that you have that specified in your informed consent, right, ahead of time. This is how I, as a practitioner, handle secrets. All right, so I'm going to quickly fit in one more. And Joe, I'm going to direct this to you initially because it's about something you said. So it says, Dr. Scorpo said that with family therapy, there can be an agreement that everyone has to agree before any one person see the record. That makes sense clinically, but patients do have legal rights to see their records. So how can we refuse if an individual in the family requests this? And Joe, I'm going to quickly add to that. I've gotten this question a lot also in the context of the open notes rule, where patients have, that immediate access if it's joint. So what would you say to that?
I would suggest making the argument, which is a legitimate argument, if there's an individual requesting records, that because there are other people present, their confidentiality and privilege issues are now combined with that individual. So it's not simply one person making a decision about their record. The fact that other patients are present changes the right of access by any one individual. So I suggest establishing that and sticking by that policy. I did indicate there's a couple of fallback positions, which in situations where you just feel like it's not worth fighting, you can offer the idea that I'll write a summary just about you, Miss X, who's requesting your records from this family therapy. And you can do that in a way that does not mention that it's family therapy and reflects only the communications made by that single party who's authorizing. It's not great, but it's a fallback. A third fallback would be to redact the record and essentially black out anything that was stated by someone who's not authorizing. Essentially, it's going to turn the record into something that's completely illegible and unintelligible, but it will satisfy the spirit of the law. So those are things you can consider if you're not able to resolve it with the fact that everyone should authorize.